So here to talk to you not as an academic, but really just a practitioner. I'm just here to just share a few stories. There's no great lessons that you'll find in textbooks from this, but I'll tell you first a little bit about myself. In addition to my education in management consulting, originally thought I wanted to be a doctor, but my father was an entrepreneur and he just got some of that business mindset into me and couldn't help it, went into management consulting instead. And in management consulting, specifically in healthcare, I ended up spending 8 years, most of that time, helping healthcare organizations find ways to run more effectively. So it's not only in terms of cost reduction, but also speed and improving quality as well. So learned a lot during that experience, learned a lot about how not to do things, not from the client side, but from me as a change agent, learning what not to do, what doesn't work. After 2 magical years here on campus, went on to Kaiser Permanente, and I'll tell you a little bit about that organization. I swore I would not be there for more than 2 years. I wasn't going to be one of those dinosaurs who are there for 20 or more. There are some colleagues who've been there for more than 30 years and are just retiring. But it is really a magical and special place, and let me tell you a little bit about that. So where I work. So for those who aren't familiar, Kaiser Permanente is the nation's largest nonprofit healthcare organization. They integrate health insurance. They have about 40 hospitals and more than 600 medical office buildings. They have physicians, nurses, and other support staff all rolled into one. As a health maintenance organization, you may have heard the term HMO. The notion of that is you get paid one monthly fee up front, and for that, the organization promises to take care of whatever you need. So our financial interest is aligned with your personal interest in terms of if you get sick, we pay more. That's not good for our finances, and that's not who we are as an organization. Keeping you healthy, preventing illness is the way that we succeed, and obviously, as a member, that's great for you as well, right? So our mission is to provide high quality, affordable healthcare services and to improve the health of the members and the communities that we serve. So it's not just the members of our organization, but it's the communities that we're in as a nonprofit organization. A very important part of what we do is provide free and reduced cost healthcare services. We do grants for education and other social services in the community. And one example, the Los Angeles fires that were happening and it's caused so much tragedy, our corporate headquarters, the Southern California corporate headquarters in Pasadena, their parking lot was turned into a first responder station to provide rest for the firefighters, provide babysitting services, food and clothing and other medical services to those affected. That is just part of who we are as a nonprofit organization serving our community. It doesn't matter, we don't check number cards, we just serve the community. By revenues, it's over $100 billion. Just for comparison, just like what does that mean? It's just a big number. By revenues, we're about the size of Target, or those who like to watch stocks, we're about the size of NVIDIA. And I mentioned the number of employees. Physicians are not technically employees, but if you added up all the people caring for the members in the organization, it's about 250,000. That is really quite an organization. And then the 12.5 million members whom we serve across 8 states in the US, if you compared that population to the United States, it would be the same population as the state of Illinois, which is the 6th largest state in the US. It's about 4% of the US population. So one company doing all of that, not just the insurance, but providing care, providing preventive care, and serving the community as well. So it's a lot. It's a really big, very complex organization. No shortage of challenges in the organization, and no shortage of things to fix, which is why I've stayed there. And at the same time, the mission is incredibly powerful. So not meant to be an advertisement, but I will say it is a really special place. I'm not here today as a representative of the organization. I'm just here as a fellow alum telling stories. And so let me tell you about healthcare. It is really, if you really think about it, so in my 30 years being in the healthcare industry, it is an amazing time to be in healthcare. I mean, a number of you are wearing smartwatches. It's just table stakes now. You just don't think about it. But if you really think about the magic of wearable technology, able to monitor your health while you're sleeping, able to detect conditions that you didn't even know that you had, like maybe a heart rhythm problem, and so on, right? The blood glucose monitors that people can just wear. My sister tried one out, really terrific. It's really amazing. It can detect early signs of disease. Another thing, artificial intelligence all over, the big exciting thing right now. In healthcare today, the technology is already existing where AI is supporting medical imaging, and they are detecting cancers that are very difficult for the human eye to see. So they're finding cancer before the human eye can find it. That's fantastic. And then you think about you've all heard about the obesity drugs, the GLP-1 drugs, and that's really, if you think about it, that's just magic. There are also gene therapies. So there are people who are born with genetic diseases. They were just born sick. Sickle cell anemia, which causes very painful blood clots. Hemophilia, where your blood doesn't clot, and just a little cut, you can bleed out. Very, very difficult to live with those kinds of conditions. You're born that way. There are gene therapies that don't just treat it, don't help you live with it, they actually cure it. It's a complete reset on life. That's amazing. Anybody have a guess on what one of those gene therapies costs? Just throw and shout out a number.
Millions.
Millions? How much? Million? Oh, you're all much more savvy than I am. Even I am surprised. So the gene therapies right now are costing between $1 million and $3.5 million per patient.
Wow.
I mean, it's a cure. But the price factors in not only the development, but the lifetime value of that person living a healthy and full life. Who can afford that? So let me tell you about, just the fact that we've got it is magic. It's almost like science fiction, but it's real. It's also a really challenging time. So those drugs, incredibly expensive. That AI technology is not for free, right? These capabilities are really amazing. In America, 26 million people don't have health insurance. That's 8% of the US population. Now you think, if you look at it another way, glass half full, 8% of the US population having no health insurance is the lowest that it's ever been. So, good for us. That's fantastic. And 26 million people, that's the population of, where's my Australian friend? That's the population of Australia, right? The entire country. Imagine that. Last year, approximately 40% of hospitals in the US lost money. It wasn't just last year. The year before was a similar, I think it was a little bit higher. On average, over the last 20 years, roughly 10 hospitals or almost a hospital a month is closing in this country. Over that period of time, our population has grown by 45 million people. So it's a challenging time. There are lots more challenges. I'm not even listing all of them, but just a few of those just to give you a flavor of it's super exciting and it's also super challenging at the same time. So here we are. Who enjoys spending more money and getting less for it? Yes, silence is deafening. That's exactly what's happening in the United States, though. We spend more dollars in raw dollar terms. We spend more per capita. We spend more on a percent of GDP basis. Any measure of spend, we spend far more than any other nation in the world. In terms of life expectancy, it is, if you Google it, you'll find different numbers, but roughly, this is from the UN, roughly the same as China. And you look at the difference in the spend. If you do it on a GDP basis, we spend 2.5 times more than China to get the same outcomes. And in fact, that's just the life expectancy, the quality of life as well. People living with chronic diseases far, far worse, far more affected in the United States than any other nation. So to me, that's a bad deal. I like a good deal. I go to Target, I lift the little sale sign and I see if it's really on sale or they just pretend it's on sale. I'm that kind of guy. This is a bad deal for me. I don't like this. And as we're looking and talking about the medical miracles that exist today, which really just, I just am so excited to be living and seeing that, but none of that matters if nobody can afford it. All right, so how do we get here? Believe it or not, the healthcare system in the United States is working exactly as it's designed to work, with all of those challenges. So I love this quotation from the former head of the Centers for Medicare and Medicaid Services, is that every system is perfectly designed to get the results that we get. So if we don't like it, that's good. We shouldn't like what we're getting for what we're paying. But it's working exactly as it's designed to. So the question for you all, you're here because you're interested in systems thinking, you have a passion for making things better. So the question for us is, how do you redesign the system to get the results that you want? So let me start by telling you a little bit about how I got, to solve complex problems, you need frameworks. Frameworks just help you package and process the information in order to do it. I'm not going to talk to you about frameworks today. Two recommendations. One is to read the goal if you haven't already. There's a graphic novel version for those of you who want. It's just a story. The graphic novel version took me like 3 hours or so on a weekend to read, and it was really easy, just a bunch of cartoons. It's just a story, but the lessons in there are really powerful. I also encourage you to watch, Yazdi Bagli is the Executive Vice President for Shared Services in our organization. He came and gave an Ezra talk in October. He provided some talk about frameworks. I encourage you to watch that as well. It's a great talk, and he makes it really, really simple. And some of those you'll find very helpful, not only for your work, but actually in your personal life as well. So a little bit about my story, my introduction to systems thinking. Anybody who's dined at both of these places, experienced both? All right. What have you noticed in terms of the service experience? Any difference? Same? Yeah? No, same? Oh, that's really interesting. So my introduction to systems thinking was, when I was growing up, my dad would drag me out early on a weekend morning, which I was a teenager, so that was any time before noon. He would believe in some father-son bonding time, and we'd go and pull weeds in the yard. Oh my gosh. So we'd do that, we'd spend a few hours doing that, and go dump the yard waste. And the reward for that was that he would go take me out to get a burger. And we didn't eat out at that time. And so that was a really special treat. So, hey, at least the reward is not the fresh air or time with dad, it was getting a burger and fries. So we'd go to McDonald's once in a while, we'd go to Burger King once in a while. And one time we were at Burger King waiting for our order, and he said, "Why is it taking so long?" And at first I thought, oh, he's hangry. He's like, I don't want any part of this. So I didn't respond. And he said, no, really, why is it taking so long? I didn't realize, like, oh, it's a real question. So then we started picking apart the process and looking at, oh, well, gosh, each point seemed to be working pretty hard. The workers were really diligent. They weren't lazy at all. Then you started, well, why do we get our meals so much faster at McDonald's? We're ordering, think about the variables. We're ordering exactly the same thing, burger, fries, drink. The production time for each of those is really about the same. It takes the same to fill a medium-sized soda at Burger King as it does at McDonald's, and same thing for all the others. Notice that the number of steps actually in Burger King, they're a little bit farther distance from the counter to the fry station, into the, so maybe a few more steps, but a few more steps can be crossed in a few seconds. Then we noticed that at McDonald's, the clerk would take the tray with them and go around and pick up the items and then come back to the front. At Burger King, they're going point to point. They go to the fry station and come back to the front and drop it off. While the fries are getting cold on the front counter, they go and stand by the drink station and wait while it filled up. There was not a second wasted from the time the drink was filled to the time that they brought it back onto the tray. But then they did the same thing for the burgers. So they're optimizing each point of the process. But the combined result was that it took longer, the workers had to work harder, and the customer was really dissatisfied. So that was my introduction to systems thinking without knowing it. It got me thinking about all the interactions of different variables and how do they work together, that just thinking about optimizing any one point does not get you the solution that you're looking for. All right, so thanks to Dan. All right, so I'm gonna tell you a few examples. I don't know if I'll have time for all of this, but we'll see how it goes. The first three are from my consulting days. The fourth one is from Kaiser Permanente, but that one is all published stuff, so I can talk to you about it. There's no secrets today. The context for the first three is that I told you that we're roughly 4% of the US population, and we're in this HMO model. The majority of the United States healthcare system works on a fee-for-service model, which is just like if you go to a car mechanic, something's broken, you go there to get it fixed. You only pay for when you go, but when you go, you pay each time. And so, the more your car breaks down, the more your mechanic makes. The similar for healthcare as well is there's an incentive for people to get sick. Now, I am not saying that people are looking for you to get sick in healthcare. People don't join the healthcare industry because they're that way. They're naturally people who really care and want people to be healthy. So that's one of the most rewarding things about being in healthcare was just the people. But the economics of how healthcare has evolved in this country was a fee-for-service model. And so economically, helping people stay healthy works against their interests. And so that's the context for the first three. So let me just go ahead and jump into the first story. So there was a hospital in the South. It was an academic teaching hospital. There were also trauma centers. So when there was a really bad crash, they got to bring a helicopter in. This is the place that they would go. They are known for extremely high quality, excellent service. This was the place, if you were sick, you wanted your loved one to go here. So excellent. This is excellent reputation. This is great. Their surgical services department had a number of operating rooms, but they had a huge backlog. They had over 2-month wait list for people with non-urgent surgical needs. And believe it or not, with all of their reputation and demand, they were actually losing money. And again, the more surgeries they perform, the more money they make. So these are some of the variables, just a few of them, there's so many. What would be a linear way of thinking to fix this problem? Just what's kind of the first thing that somebody might think to do? If you're a consultant, they said, oh, we've got this problem, this backlog, and we're losing money. We need more surgeries to make more money so that we can get profitable. Yeah?
Take on more cases, you work overtime.
Work overtime? Yeah, that's definitely one solution. Other thoughts?
Better infrastructure so that they can perform more surgeries, hire more doctors.
More infrastructure, right. More operating rooms maybe?
Criticals, yeah.
Right, because they're all backed up.
Mm-hmm.
You need more capacity.
Yeah. They have clients already, so they need to, they have patients that are backlogged.
Right. So that and more, Hire more staff, work overtime, no overtime. No money. We're already losing money. We don't want to pay people overtime. The physical plant of the hospital is very constrained, very expensive to build and expand. So, and also they're losing money, right? That's very, very expensive to build. So there are also things like when staff are represented by unions, their jobs are prescribed of what their job is, and then if they do something that somebody else's job is, then you're taking work away from somebody else's job. So I wasn't familiar with this before I worked in a unionized environment, but there are sharp lines between what one person can do and another person can do, and that has to be respected. That's the way the organization and their labor unions have agreed to those terms. So what we did was we did two things. So I said no staff, but we actually did add staff. And so let me go back. I put this little airplane logo for a reason. So I trust most of you have flown before. And if you think about surgical services like an airline experience, think of the surgeon as like the pilot. You've got the nurses around supporting the surgeon during the procedure are like the cabin crew. And then you've got ground crew. And so they handle the bags and refuel and so forth. What are the ground crew doing while the airplane's in the air?
In an airport situation, they're preparing for the next plane coming in. But if I wanted to extrapolate that for a hospital setting, they would either be cleaning or making sure the medication is there for the next case. And that's my guess would be.
Yeah. So they've cleaned. So in this situation, the ground crew are like the cleaning staff, the environmental services staff. So they've gone to do one operating room, then they're waiting for the next one. They're sitting around, right? When hospitals or any organization is losing money, they're looking for like, where can we shave just a little bit of money here and there, just wherever we can get it. So you see people who appear to be just sitting around with nothing to do, easy target, right? Linear thinking, like, hey, where is their fat? Let's cut that. What happens if you cut down the ground crew to the point where they can only serve one airplane at a time, but 3 of them land at the same time? And that's just exactly what was happening in surgical services. So, okay, back to this. So we added 2 things. One is we added some extra cleaning crews because at, I don't remember, but it's something like $17 an hour versus a couple $1,000s an hour for an operating room, whether it's in use or not. It was a bargain. 2, we added what we called a charge nurse. I call it air traffic controller. This person's one job, only job, was to monitor everything that was going on in the different operating rooms and say, hey, how's the case going? Are you running a little bit late? Oh, you're 10 minutes out? Okay, hey, cleaning crew 2, get to OR room 1. They're gonna be done in 10 minutes, wait outside the door. Room 3 is running late? Okay, so cleaning crew 3, forget room 3, they're gonna be running late, go to room 1, wait outside their door. It's gonna be 30 minutes, but you go wait out there, they're gonna be done before room 3 is. All day, that's what she did. As a result, there's one more thing. Because they're doing that, so as a trauma center, they actually reserved one of their operating rooms for emergencies only. No cases all day long unless an emergency came in. But the reality is when they get a call saying, hey, there's been a bad accident on the freeway, we're sending a helicopter to pick them up, they'll be there in about 45 minutes. There are a number of small cases you can get done in, out, clean, and ready for the next case in 30 minutes. And they weren't utilizing that. And they weren't because they didn't have faith that room would be available the second that trauma patient wheeled in the door. But with the air traffic controller, that gave them the confidence they could, so they were squeezing in extra small cases in there too. So as a result, they literally doubled the volume in the same operating rooms, no expansion, just a few staff,
Important stuff.
very few, but really critical, who appear to be sitting around half the time with nothing to do. But what a critical role that is. Their backlog went from over 2 months to less than 2 weeks. So if you think about that, like, oh yeah, that's great, more money, more level. Think about it from a patient care perspective. People are waiting for 2 months. They're getting their care now so much faster. That leads to better outcomes. The longer you wait, it's not just that one hip or knee problem that exacerbates, but the inflammation and other problems that you have travel throughout the body as well. Just your whole health gets worse over time. As a result, we had more cases. We ended up spreading the fixed costs of the operating room over more cases. We ended up lowering the cost per case by more than 20%, which means also they didn't have to raise prices for their customers and return to profitability. But so all of that is good news. But the thing that I feel most proud about is the fact that people weren't waiting anymore for their care, right? That's what really matters. And that was enabled by helping them run their operations better. Questions about that example? Yeah.
I'm just wondering, how did you know, things were improved to keep the ORs operating or getting more operations?
How did we know that the cleaning crews were the constraint?
Yeah.
Okay, one, read the goal. You learn about theory of constraints. And one of the things that in the theory of constraints, it is, I used to think like end-to-end map every bit of the process and every little thing, and then you try to optimize all the different parts, kind of like the Burger King example. Theory of constraints, it says, just look around. And in this case, we just talked to staff. In fact, the further you get from management, the better, because they really know exactly what's causing the problem. You don't have to do all of these. I mean, it's good to support with data and time analysis, but just to get started to figure out, everybody knows what's holding things up. And you go there and say, okay, what would it take to free that up? Everybody knew in this example that people were waiting for the cleaning crews. And so what I meant, the reason why I brought up the job separation for the union represented staff, nurses were in unions, cleaning staff were in unions. Nurses were sitting around with literally nothing to do until the room was ready, but they couldn't go in and help clean to get the case started faster because of the segregation of responsibilities. So, yeah.
So I don't understand, is this a situation of a blockage or a constraint? I read the book and they talk about blockage and constraint for the Hervey situation.
Mm-hmm.
So I don't understand, would you classify this situation as a constraint or a blockage in the process?
Without going into all of the theory of constraints, I would say, to me, that this was a constraint. There was a limited capacity, and we either had to slow. What happened for them to be in this situation was everybody had to slow down to what the cleaning crew could do, which is what led to the limited number of cases they could do. And so if you then attack the constraint, we expanded that. We gave them more capacity, not in the rooms, but in the cleaning crew. In fact, if you added more rooms, we would have spent a lot of money. They would not have gotten one more case done. Okay, good. All right, so second example, in an emergency room, this was in a community hospital, and their emergency room was packed to the gills. For some of you may not know that there's a law in the United States that if anybody comes to the emergency room and needs healthcare services, it doesn't matter if they're a member or not, it doesn't matter if they can pay or not, the emergency room and the hospital are legally required to provide them healthcare services. So think back of the 26 million people without insurance, and there are millions more who are underinsured, where they don't have a primary care doctor to call when they're sick. Where do they go when their son twists their ankle? Emergency room, right? So they were packed. There's also, in a fee-for-service hospital, the emergency room is the gateway to their inpatient care. So it's not just about making money for the services provided in the emergency room, but if they can find the people who need inpatient care, get them to that care faster, and they're coming to us instead of somebody else, then that's also more revenue. So, hate to talk about this, even though I'm like an economics guy, I'm a finance guy, I hate to talk about the economics of this, but this is just the reality, it is also a business. And so, getting more patients through the emergency room was really important for their economics, as well as for the timely care for the people who are showing up. So we've got different variables, many different variables in that situation as well. In this case, I'll just share that what they did was, again, no money to expand. They couldn't add staff because it was losing money. They added what's the equivalent of like a 10 items or less checkout lane. So they didn't have, their emergency bays were packed. They didn't have room. Their physicians and staff were juggling as many patients as possible, just the ultimate in multitasking. But what do we learn about multitasking? The research shows that the brain doesn't actually multitask. Goes to one, then switches off, transitions. You lose where your train of thought was. You lose that systems thinking that was in your brain of finding a good solution. And then you have to start over, and then you turn off and then go to the next. So you're not actually functioning efficiently. So with the fast track, we took one nurse practitioner who's able to prescribe medication, but not a full MD. There was a conference room next door, and we just tried it out. Just, hey, let's have one NP, take all of the sore throats, the twisted ankles, things that don't require medical equipment in a medical facility, really, and try them out in the conference room. They got 2 exam tables that were on wheels, just set up a curtain between them, tried it out for a while. Her one job was to bleed as much, I shouldn't say bleed, to take as much volume off of the emergency room staff as possible. And even if that nurse practitioner had a break, was not allowed to go to the emergency room to go help them out, because then again, she would be late for the next person who needed some less acute care. So that was the one job. Ended up reducing waiting time by 40%. Patient outcomes, again, in terms of avoiding the delayed care. I've been with my aunt lives right next to us. She's been another second mother to me. She has been in the emergency room a couple of times, and the wait was terrible. And I'm thinking like, well, if they did something more like this, which they didn't in that hospital, if they did, she could have been seen much faster and gotten the care that she needed, and her health outcomes would have been better. It just happens that by doing that, you're improving the quality of healthcare, you're improving the timeliness, and the financials just naturally improved out of that. So it's not starting with cutting costs or finding a way to improve the financials. The financial improvement is a result of improving quality and speed. All right, story number 3. Who's watched a medical drama? All right, what are the doctors always shouting when they're in a hurry? Sorry?
They were running through the corridors.
Yeah, they've got a patient, they're bleeding, and they're shouting, I need something stat, right? From the Latin statum, right? So I need something stat. So in this hospital, the time they send, a physician would send a sample of blood or tissue to the lab, to the time they got the results back, was so bad that they were seeing significant erosion in the outcomes of their patients. Their patients were getting sicker, some of them were even dying because the lab was so slow. So if you're a physician in that situation, you mark something stat, you're not getting the results fast enough, what would you do as a doctor or nurse? Yes?
What I've done in the past, I just go up to the lab.
You go to the lab, right? Yeah. Before that, what they did, they marked it double stat. And then double stat didn't work. Didn't prioritize their lab result to the top. Everybody started marking theirs double stat as normal. Nobody ever ordered a regular lab test, and very few ordered a single stat. They did double stat. It was becoming normal. Then there was double stat with the nurse calling them, where is this specimen? Drop what you're doing, go find it right now. That didn't work. When that didn't work, then the doctor would call and explain how critical the patient is. if I can't get the treatment started in the next few minutes or the next half hour, this patient may die. I'm serious, I need it now. So they got double stat with the nurse call, double stat with the physician call, and they were still struggling to get anything through that lab. It turns out that half of the staff were spending their time dropping what they're doing, trying to find that specific specimen, then clear the machine, get that one specimen through, even though it can handle many, just get that one through, and then provide the results. And when we looked at the capacity, the number of tests that were being ordered compared to the capacity of the equipment, woefully underutilized. There was more than enough equipment. When we looked at what could the staff do if it was more normal hospital, there was more than enough staff. So equipment wasn't a constraint. It was the definition of what is a stat, and the service levels weren't meeting. So what they did in this situation was they sat down with physician leaders and they wrote down what is a stat. It is truly must be provided within 30 minutes. I don't remember the exact definition, but something along the lines of must be provided within 30 minutes for a life-threatening kind of situation where intervention must be provided in the next couple of hours. So something like that, they agreed to that. The lab also promised, we will bring in people nights, weekends, overtime, but we will do whatever it takes to make sure that the stats really are delivered within 30 minutes. The regular urgent gets delivered within 2 hours, and then everything else within 4 hours, unless it's like a culture that needs 24 hours to be developed, so something like that. Really, the doctor said, I don't believe it, but if you can do that, I'm on board. So then the administration and the physician leadership, they got together and said, okay, we're gonna give it a try. And they did. There was a need to enforce the definitions. We knew that some people were gonna try to not trust the system and order things stat anyway when it wasn't. So they did have a mechanism for catching those and asking them to please, this doesn't seem to fit the definition of stat. And they brought in for a period of roughly 2 months, it was all hands on deck in the lab, and they were working nights, weekends, overtime. It was a little bit more of a cost. But as a result, they were shocked. They didn't think that they could reach it, but they thought, wow, if we can get close, maybe it'll be better. They far exceeded those turnaround times. They were much faster. Same staff, same equipment, same size of the lab. Okay, good so far? All right, looks like about 20 minutes left. I have one more story, or you wanna just go to questions?
Yes.
One more story?
Yeah.
All right, so this is roughly, on average, roughly 15% of people who have stayed in a hospital end up coming back to the hospital within 30 days because they weren't fully healed. If you really think about that, that failure rate, if you think of that as a failure of the system that was meant to take care of them, that's really high. I don't want to be one of those. There are a number of reasons for that. Among them, food insecurity. So when people don't have enough food to eat after they go home from the hospital, then they can't heal properly. Simple idea, right? Makes sense? This was published, so I can share with you, a quarter of Kaiser Permanente's 12.5 million members are food insecure. They can't rely on a meal. For our Medicaid members, roughly half of them are food insecure. So we tried an experiment. And this was actually supported by experiments done and research done by a number of other healthcare institutions, and we thought, wow, that sounds really great. Can we make that work in our organization? So we started providing free meals to those whom we found don't have enough food at home. We send them home after their hospital stay, we'd give them free meals. Great. Didn't work. You're shaking your head, you already know?
I was a ER social worker before.
Oh, okay, so why doesn't it work?
It's just not, it's
there's other factors to like the social determinants of health, right?
Absolutely, there are many other factors, and among them, in this situation, it's not just the patient, the whole family was hungry. So when we sent food with the patient, they were giving their food to their family members to at least have something in their stomachs that night. So they were not healing properly, they were coming back to the hospital. So for food insecure people who are discharged from the hospital, there was twice as likely to come back to the hospital. So we did give them food. We did expand it to their family members. This was an experiment. I was part of an innovation team where we're kind of testing and learning different ideas and seeing how it works. And so as a result, the sample size was too small and it was too short of a study for us to get like statistically significant results, but we got enough positive indications, including the patient's wellness improved, and there's a lot of research that shows that if the patient's wellness improves, just the feeling, good feelings, the lack of depression, then that contributes to faster and more effective healing as well. So the organization, I'm really proud of this, has taken that learning and they said, all right, we're all in. So Kaiser Permanente launched last year a Food is Medicine Center of Excellence. And so they're now working to integrate food access and nutrition into the medical care services, just like a surgery or anything else. Okay, so with all of these and many more stories I could share, here's what I took away from it, is that when you think from a systems perspective, right, just giving that patient who was hungry food was not enough. You have to think, what are the other variables, the other social factors, right? Their family was hungry. When you think from that systems perspective, you can have really impactful results that cost very little, if any, money, low tech, if any tech, and if you just start layering these changes on top of another, the impact to the whole US healthcare system or any healthcare system can be really profound. All right, so that's what I've got for today. Questions?
Thank you so much, Jay, for sharing your experience, vision, and wisdom through these very powerful examples in different settings. Now we open up to any conversations, thoughts, and questions you guys have, both in the Zoom. We'll come check the chat and also in Zoom, so feel free to.
Yes.
Thank you so much for speaking with us today. One question I had was related to your last example,
Mm-hmm.
the home healthcare. Obviously, Kaiser's in a very great place that with your capitated model, you have that flexibility to do that. When I was at a hospital over the summer on a fee-for-service model, they were having problems with reimbursement strategies for those models, and I was wondering if you had any suggestions in those cases.
Yeah, so the Centers for Medicare and Medicaid Services, as I understand it, I haven't looked this up really well, but somebody was telling me that in certain states, the states combined with those government agencies have include social services like food and other needs, social determinants of health, included that in the reimbursement for some of those. But if somebody is insured by one of the for-profit insurance companies, it's difficult because the incentives aren't quite perfectly aligned. Yeah. Yes.
In the example about the cleaning of the ORs and using more staff for the EVS to come in, did you use that with like the ER and like the floors? Because I feel like a lot of time the ERs are overpacked because they can't get into the floor because the rooms are empty. Did you use that as well?
Yeah, absolutely. So same idea of the surgical services, but for the nursing floors to get the rooms turned around and unpack the ER. In this particular project, it was just for surgical services, but that lesson for that organization was so profound, I would be really surprised if they didn't do that. But it's also, you can just apply that same idea in a number of different areas. All right, all it is finding where things are getting gummed up And you just ask people, where are things getting stuck? Where is that friction point? And then just look to reduce that friction. Yes? Hi.
Thank you for speaking with us. I just wanted to ask, like, what is your strategy for the first stages of intervention, like speaking and communicating to different stakeholders and people?
Gwen, would you mind saying it a little louder so everyone can hear you? And you can also introduce yourself.
Hi, I'm Manuel. I'm a junior, but I actually interned with Kaiser my freshman year. I just wanted to ask your strategy for the first stages of intervention, like communicating and speaking with patients or other executives and physicians, and I guess like tips on communications.
Leon has been present in the last class you taught as well.
Oh, very good, thank you. Communication strategy, when you're trying to drive change like this, like where do you start? Number one, and you would find this from reading the goal, is first just getting people who are interested parties in whatever problem you're trying to solve. The hardest thing is defining the goal. Is it to make money? Is it to get to patients faster? What is it? Is it to improve the quality of the lab results? That getting people around a table to talk about that. Once you have that clarity and everybody's aligned on what are we here to do, then you can move really fast. Then you just have those conversations about, well, where do we think things are getting gummed up? Look for friction. So I wasn't really talking much about friction today, but I really see myself as a professional friction reducer. So you look for find places where there's friction and find ways to reduce it, where it's not productive, or introduce friction where there needs to be some guardrails around something like that. But again, the frontline staff will know. But this is a lot of why change initiatives and organizations fail, is because everybody goes to the meeting and they think that they're solving the same problem, and the end outcome of their work, they think it's the same. They are saying the same words, but when they are actually defining the metrics of success, hey, we have crossed the finish line. When these 4 things are true, everybody has a different idea in their mind. So they're pulling a little bit in different directions the whole time. And they end up with a solution that doesn't actually work and doesn't last. Yes?
Hi, I'm Katie. I'm wondering, in the lab example, you talking about friction, how did you realize that it was more of an issue of definition rather than friction within the system, and you should redefine the label of what STAT means rather than just creating like an entirely new system of organization within the lab?
There was some of that is you just go and you hear the stories of the staff. Again, you talk to the frontline staff. What's causing you friction? What's making your life difficult? And there's like, these calls are driving me crazy. I can't get anything done. So it's kind of easy as that. But then you do need to back it up with some data. Sometimes you don't. This time it just made sense because there were, again, different ideas of what success meant. And some of those believe strongly have to add more equipment and more staff. And it's the finance people who are telling us there's no money. But so we had to then do some analysis to show that no, you don't need more equipment. And if the staff was doing a normal level of stats, then you have more than enough staff. Does that help?
Yeah, thank you.
Sure.
I have
Yes.
a question. Hi, I'm Diana.
Hi.
So when
And you can tell me about what's your field?
I'm a first year master's student in health administration.
Mhm.
So I'm curious, how do you get people to like kind of start moving away from this linear type of thinking and going more into system thinking, when in a field like healthcare there is so much like pressure and time constraints.
Yeah.
So people want to like act fast, right? And like solve the
That's right.
problem soon.
That's
And
right.
sometimes we just talk about like that's not the solution, like the best solution.
That's right.
So,
So how do you get non-systems thinkers to think in a systems way when they're under a lot of pressure? It's not just in healthcare, it's in any organization. Everybody's under pressure. Everybody's under a lot of stress. And so the reaction is very natural. I think it's just instinctual to react. A little bit of fight or flight when people are stressed, right? So you get a fight or flight kind of solution. It's very difficult to take good policy and run them. This is why you're here. This is what you're studying. And you need to go and become evangelists to your fellow classmates. And when you go into work, to show people what it's like to take just a breath. Let the stress come down a little bit. Bring in a couple of additional variables. Just talk to a couple of frontline staff. And, hey, this is what I learned. Help them learn how to think from a systems perspective. But this is what's so exciting about being here with you, and this is what you're studying. It took me a long time to figure this out. I mean, it started at Burger King, but my journey was actually quite long to get to this point, and I am by no means any kind of master. I'm just telling you the few things that worked. There are a lot of things that didn't work, but go and preach. Yes?
I have a question. My name is Jen, and I have a background in design.
Mm-hmm.
So I read the book like ago. It says like in the system we're supposed to find like systems driven, and we're thinking about how to improve it like consistently and solve it. And I'm thinking about for like the healthcare setting environment from your point of view, like what's gonna be like the constraint, right? The most urgent issue we want to improve in the environments that we can provide.
What's the most urgent constraint in the US healthcare system?
I mean for the more like healthcare environments, like the hospital environment. Because I have a background in design, but I'm really wondering like what's the most urgent issue, like you guys thinking is most important that you want to do.
And design, you mean broadly, right? Not just in inpatient, you mean in general in healthcare, what's the next trend or most pressing trend?
I really think affordability. And I heard our organization's leaders talk about it. I didn't fully understand it. Now I really appreciate what they're saying. And other leaders in the healthcare industry as well. Again, these medical miracles are amazing, but look at how much we're spending and we're still not getting the results. We've got better technology than any other nation in the world. We've got better solutions and treatments than any other nation in the world. They come here, right? People from overseas with means, they come here to get treatment for cancer or whatever is afflicting them. So we've got the best, but people can't afford it. And I think that gap is likely to get worse. And that's very concerning to me. So these kinds of solutions that I'm talking about, just one little hospital, one emergency room, or one lab, one little thing. But if you all go and you evangelize others, and we have an army of people with systems thinkers, one layer at a time, making these changes, the whole system will change. We can afford all of these miracles and more. But we have to we already know how to fix things now. We just need to go do that.
Thanks.
Yes?
Do you have any tips for selling that initial investment or upfront cost for research or new programming? Because I know that can be kind of a hurdle when we're trying to like cut costs to actually invest in the research and sell that.
As I heard the question is that there's some sort of upfront investment. It takes money to save money or make money. And so how do you convince leaders to do that? As I was showing, typically it takes very little. What it does take is it takes a little bit of time and somebody taking a breath to think from a systems perspective. So you can do this with internal resources. And even we were just talking last night about just finding a way to turn my used to be 14-hour, 6-day-a-week work week down to something much more manageable. My workload's actually expanded, my responsibilities have expanded, but I'm working less. How am I doing it? It's by finding priorities, thinking about what is the outcome I'm trying to make? Why does that matter? And if I've got clarity on that, then I just focus on those few things, and I found I was spending a lot of time doing things I didn't need to do. So you do that for a couple of people, you release them, and then allow them to do this kind of work. And it pays for itself in no time. You need very little. There are times when you do need some investments, but there's so much you can do without. Yes?
Hi.
Hi.
I'm wondering, has Kaiser ever invested in preventative healthcare?
Oh yeah, absolutely. right? We can't survive if we don't catch disease early and prevent it as well. So vaccination rates, screening rates, and so forth. So we invest a lot in that. And then even things like providing food to people is a way of preventing them from coming back to the hospital, as one example, right? Or preventing other diseases as well. So yes, absolutely. Our model relies on prevention and the investments in prevention to avoid the expenditure of more acute healthcare, which nobody wants.
The follow-up question for you, Jay. At Cornell, we try to approach the problem from multidisciplinary. So right now, there are students from architecture, information science, health administration, public health, hospitality, behavior and design, engineering, and more around the table, and they're gonna try to look at it from a systems angle. Building teams from very diverse disciplines is unconventional and
Right.
can come with challenges because then we have to come up with a common language. You shared something super interesting as well, as you said, bringing, and you said you're a professional friction optimizer. And innovation, where we're trying to apply innovation in healthcare here at Cornell, requires just the right amount of friction, not so less, not
Right.
so more.
Right.
And so could you, from your many years of experience in leadership, could you advise, because we focus also on transdisciplinary team building, and that's how we even start our conversation, because we know we have to have a language first. Could you advise from your experience what it takes from your bird eye view to have productive teams that can go in and make such high impact, low cost, transformative effects? Because it requires multiple angles, but how can we be really moving toward a productive team when we have so much diversity?
Oh yeah, absolutely. So it goes back to the definition of the goal. If you even have the same type of person, like all doctors or all nurses in a room, and you're trying to define a problem and what the solution is, you'll get very different answers, even though they're all from even the same department, same job. And so even more important when you have a multidisciplinary team is to define what you mean, and not just at the surface level, but go down, okay, what does that mean? What does that mean? Getting down to like metrics. So we have running together our three-legged or 10-legged race. We've run and we've crossed the finish line. Imagine what that is. We've crossed the finish line, crowd is going wild, but what does that actually look like? And when you can do that and define that together, then those very different ways of thinking become incredibly powerful together. But if not, then it's actually worse than people from the same department who still have different ideas of what the definition of success is. So that's the hardest part.
Super interesting. I hope that we can implement that. Given the interest of time, we have to wrap up the questions. I just want to go back to the chat. Al, or other folks on the chat, if you would like to make a comment. Otherwise, we have to wrap up for the time reasons. While if the folks on the chat want to comment if they would like, I would like to invite Grace on behalf of all the students, Cornell Systems Engineering, Human-Centered Design, and all Cornell and the Health Innovations class. Grace represents that, so thank you so much for joining.
Thank you.